Hospice care represents a specialized component of end-of-life services funded primarily through Medicare Part A, designed to support terminally ill individuals with palliative measures rather than curative interventions. In California, particularly within the Los Angeles area, patterns of suspicious billing activity have emerged as a focal point for scrutiny, revealing instances where federal funds allocated for patient comfort appear diverted through elaborate schemes. These developments underscore the tension between providing compassionate care to vulnerable populations and safeguarding taxpayer resources from exploitation, as documented through detailed on-the-ground examinations of operational sites and billing records. Independent investigations have played a central role in illuminating these issues, with one prominent content creator conducting extensive fieldwork and data reviews to expose rapid billing surges and questionable facility setups. The work highlights specific operations that bill substantial sums over short periods while maintaining minimal visible activity, contributing to broader claims of over $170 million in suspect expenditures tied to ghost entities. Such efforts have garnered widespread attention across media platforms, prompting discussions on state-level responses and comparisons to earlier estimates of large-scale fraud in home health and hospice sectors. This analysis examines the foundational elements of legitimate hospice delivery alongside the techniques of fraudulent activity, with particular emphasis on administrative structures, financial transactions, and regulatory processes in California. By dissecting these components, the examination reveals how systemic features enable certain practices to persist, emphasizing the interplay between program design, operational realities, and preventive measures. The discussion proceeds through a structured evaluation of each aspect to provide a comprehensive understanding of the dynamics at play. The legitimate framework of Medicare hospice care. Medicare hospice benefits operate under strict eligibility criteria, requiring a physician's certification that a patient has a life expectancy of 6 months or less if the illness follows its normal course, coupled with the patient's formal election to forego curative treatments in favor of palliative support. Once approved, the program reimburses certified agencies through a fixed daily per diem rate that encompasses nursing visits, aid services, medications, supplies, and counseling, ensuring comprehensive comfort care without significant out-of-pocket costs to beneficiaries or their families. This structure prioritizes home-based delivery, where the majority of services occur in the patient's residence, whether a private home, assisted living facility, or nursing home, thereby aligning resources directly with individual needs rather than institutional overhead. Administrative offices serve solely as coordination hubs for record maintenance, staff scheduling, interdisciplinary team meetings, and compliance documentation, not as primary sites for patient treatment. Agencies maintain responsibility for all core services through their own employees, with limited exceptions for temporary inpatient care in approved settings when symptoms cannot be managed at home or for caregiver respite. Contracts for such inpatient placements remain under the agency's oversight, preserving accountability for the full spectrum of required interventions and preventing any delegation that could undermine professional management standards. The framework explicitly prohibits arrangements where an agency functions merely as a billing intermediary funneling services to external providers without direct involvement, as this violates conditions of participation that mandate full operational control and service delivery. Eligibility determinations and ongoing recertifications demand face-to-face encounters and detailed documentation, creating a paper trail intended to verify medical necessity and actual care provision. In this manner, the system channels federal funds toward genuine end-of-life support, distinguishing it from programs lacking such layered verification steps and establishing a baseline against which deviations become measurable. The anatomy of hospice fraud schemes. Fraudulent activity in hospice programs typically begins with the enrollment of ineligible individuals, including those who are not terminally ill or healthy seniors lacking proper consent, facilitated by false physician certifications or the unauthorized use of Medicare beneficiary identifiers. Once enrolled, agencies submit claims for services never rendered or medically unnecessary, employing upcoding to inflate care levels and generating revenue streams disproportionate to any actual interventions performed. This approach exploits the per diem payment model, allowing rapid accumulation of funds through high-volume billing without corresponding expenditures on staff, visits, or supplies. Shell companies emerge as a core mechanism, established at empty lots, strip malls, or single addresses housing dozens of entities to create an appearance of legitimacy while conducting no substantive operations. These setups facilitate the diversion of payments into personal accounts or layered corporate structures, where proceeds support lavish lifestyles such as luxury vehicle purchases rather than patient care. In some instances, funds transfer to additional fabricated healthcare entities, obscuring trails through repeated laundering steps that complicate traceability and prolong the scheme's viability. Kickback arrangements further complicate the landscape, involving payments to recruiters, physicians, or affiliated parties for referrals of ineligible patients, sometimes resulting in profit sharing between the initiating shell and a quasi-operational provider. Inadequate or non-existent care not only drains program resources but also undermines legitimate agencies by diverting funds that could support authentic services, while exploiting the vulnerability of elderly populations through identity misuse or coerced enrollments. The cumulative effect manifests in billions of dollars in improper outlays, highlighting vulnerabilities inherent in a reimbursement system reliant on post-submission verification rather than upfront validation of every transaction. Investigative revelations from California hospice operations. California has surfaced as a primary location for concentrated hospice fraud activity, especially in the Los Angeles region, where enrollment and billing volumes have exhibited dramatic increases reaching approximately 1,000% in select metrics over recent periods. One detailed examination documented a single agency billing $3.1 million across 19 months for over 500 patients, achieving an average of $6,000 per beneficiary through roughly 24 claims per patient utilizing only 2 service codes and generating around 12,000 total claims. Such velocity, combined with operations housed in rundown buildings situated in high-crime neighborhoods marked by visible homelessness and boarded structures, raises questions about the authenticity of service delivery. Shell entities proliferate at clustered addresses, including instances of 30 or more similarly named operations sharing one location or even hundreds registered to a single building, often appearing abandoned with accumulated mail, non-functional phone lines, and no observable staff or patient activity upon inspection. Operators associated with these setups reportedly maintain extravagant personal expenditures, such as driving premium vehicles, despite the apparent lack of functional infrastructure, while agencies activate quickly, bill aggressively, and dissolve or relocate upon increased scrutiny, occasionally directing principals toward destinations including Armenia or Russia. Public records and site visits have linked these patterns to both hospice and overlapping daycare fraud, amplifying the scale of suspected improper billings to over $170 million. The revelations have circulated widely through digital platforms and traditional media outlets, including dedicated news segments and commentary from prominent figures addressing state administrative responses to the documented irregularities. Comparisons to prior assessments estimating billions in regional fraud underscore the consistency of observed indicators, such as rapid license alterations and disproportionate per-patient payouts exceeding national averages. These findings emphasize the role of geographic concentration in amplifying systemic weaknesses, where minimal physical presence coincides with maximal financial extraction from federal programs intended for terminal care. Administrative structures and financial flows in fraudulent enterprises. Medicare disperses payments directly to certified hospice agencies through electronic transfers triggered by submitted claims, with the expectation that funds support documented care delivery including personnel salaries, medications, and operational necessities. In fraudulent contexts, however, the absence of actual services means proceeds remain unallocated to legitimate expenses, instead entering personal or intermediary accounts almost immediately upon receipt. This direct flow bypasses intermediate checks, enabling operators to access substantial sums before external reviews activate, particularly when billing patterns initially evade automated detection thresholds. Laundering occurs through sequential transfers across multiple bank accounts or interconnected shell entities, often incorporating unrelated or fabricated healthcare operations to create distance between the originating fraud and final expenditures on personal assets. In the predominant model, funds are retained entirely within the initiating operation for direct personal gain, with no provision of care at any stage. Alternative configurations involve partial transfers to semi-functional providers, where proceeds are divided following kickback agreements that reward patient referrals or false certifications, thereby distributing gains while maintaining a veneer of distributed activity. Accountability mechanisms rely on post-payment audits and record reviews to enforce repayment of overages or initiate sanctions, yet the speed of fraudulent cycles frequently allows dissipation of assets prior to intervention. Clustered registrations and address anomalies serve as indicators for deeper scrutiny, yet the administrative emphasis on billing compliance rather than continuous physical verification permits temporary functionality sufficient for initial approvals. The result is a financial ecosystem where federal resources intended for palliative support instead sustain networks designed explicitly for extraction, with limited immediate recourse once funds enter private channels. Regulatory inspections and systemic oversight challenges. Oversight begins with initial certification requiring unannounced on-site surveys conducted by state agencies or approved organizations to confirm operational status, including the presence of active patients and compliance with all conditions of participation. Recertification occurs every 36 months through similar unannounced visits, supplemented by targeted site checks and data-driven reviews that flag anomalies such as excessive billing volumes or address concentrations. California enforces additional licensing protocols, incorporating a moratorium on new approvals since 2022 that demands demonstration of unmet regional needs alongside enhanced denial and revocation authorities. Despite these protocols, resource constraints within survey agencies contribute to backlogs, with a portion of providers overdue for required evaluations extending beyond standard intervals. Complaint-driven inspections and validation surveys address immediate concerns, yet the volume of licensed entities in high-activity areas outpaces routine capacity, allowing certain setups to maintain compliance appearances long enough for substantial billing before dissolution. Multi-agency task forces coordinate responses, resulting in license revocations numbering in the hundreds and ongoing evaluations of additional operations, yet the reactive nature of many processes means intervention often follows rather than precedes financial extraction. Funding allocations support program integrity activities through dedicated channels for audits, site visits, and enforcement referrals, yielding measurable recoveries relative to investment. Nevertheless, the scale of activity in fraud-intensive regions reveals limitations in sustaining proactive, continuous monitoring at every location, particularly when schemes emphasize rapid activation and relocation. Enhanced dedication of resources toward initial and ongoing verification could strengthen barriers against exploitation, aligning preventive capacity more closely with the volume of disbursements and the speed of emerging irregularities. Conclusion: Hospice fraud exposed. California's Medicare billing schemes and oversight gaps revealed. The interplay between legitimate hospice structures and fraudulent adaptations demonstrates how program features intended to facilitate compassionate care create openings for diversion when operational verification lags behind billing activity. In California, concentrated patterns of shell formations and identity misuse illustrate the efficiency with which federal per diem payments can be redirected absent robust upfront controls, underscoring the necessity of synchronizing inspection frequency with enrollment growth. Administrative offices functioning as coordination points rather than care sites further amplify reliance on downstream documentation, which fraudulent entities readily fabricate to sustain cash flows. Financial mechanisms reveal direct payment pathways that, while efficient for compliant agencies, enable immediate access for those intent on laundering or personal appropriation, with layered entities and kickback divisions extending the concealment period. Oversight frameworks incorporate unannounced surveys and moratorium measures to counter these tactics, yet persistent resource limitations and cyclical scheme adaptations indicate that current allocations, though productive in recoveries, fall short of matching the pace of exploitation in identified hotspots. The documented scale of suspect billings highlights the imperative for proportional investment in preventive infrastructure to protect program integrity. Ultimately, the California experience affirms that effective containment of hospice fraud demands integrated enhancements to initial vetting, continuous site validation, and financial tracing protocols. By addressing the documented gaps through sustained resource commitments, the Medicare system can better fulfill its mandate to support terminally ill beneficiaries while minimizing unwarranted losses, thereby preserving both fiscal responsibility and the trust essential to end-of-life care delivery. This balanced approach ensures that palliative services remain accessible without succumbing to the operational vulnerabilities exposed through detailed examinations of regional activity.